here's what I plan to do with LabMed. I am going to, for the diabetes part, I'll take care of the pancreas. And I will need to look at it tomorrow. But I think I'll just probably pull everything together and put it in one handout for you. And that's what will be on the first exam. Probably, I'll have to think it through, but I probably 4. We'll see. But I'll get back. So it'll be at least 4 questions, no more than 8. Then I'm going to move that what you had today to a second part. I will take responsibility. I obviously did not communicate well enough for it to come off like I had expected. So that's my fault. So I'll take what the adrenal, pituitary, thyroid, hypogonadism, move it to the next section. But I think what I'm going to do is break it up and make sure it's embedded in each of the presentations. That way the gap between now and when you actually have to apply it will be shrunk. And then we'll put that information on the second test. I've communicated that only in an email to to Professor Reggio because she wasn't around when you all were talking about today's presentation. So if she comes at you with something different, just let me know and I will circle back with her again if I don't see her today and she gets to you all before she reads my email. Will that suffice for now? Is that good? Anybody have problems with that? Nope, I see smiles. Okay, that's the way we'll go then. So, let's see, Julie, you have a guest. You want to introduce her?
This is Diane.
Diane.
Hello.
Where are you from?
Actually, I guess I can say I'm from Oklahoma now. Army brat, moved everywhere, but I have my master's and bachelor's from OU, and I currently work at the State Department doing the most exciting work ever, reviewing policies. So if you know wellness policies, government policies, business policies.
So I assume you're interested in
Yes,
PA
yeah, I'm
program?
a dietitian by training. I currently am a dietitian, still licensed in Oklahoma. I just review policies for the state right now. So yeah, I'm very interested. I have a dad that's a dentist, a brother that's a pharmacist, so healthcare kind of runs in my family. And my brother just graduated from OCU MBA program, and my mother is an alumni of OCU.
Oh wow, lots of roots. Okay,
Yeah,
ties.
so definitely I'm ready for a new change, and I've always been interested in PA and that aspect of it. But early on, I wasn't quite ready.
You think this will be enough of a change for her? Okay, we're glad to have you today.
Thank you.
Okay, so today what we're going to do is cover the medical evaluation of a person with diabetes. This may be different than they usually present clinical medicine topics to you. I don't know, because I'm not usually in on that part of it. But the way I'm doing it is, this is the recommended medical evaluation content for somebody who is new to your practice with diabetes or has a new onset diabetes. It would probably take you about 1.5 to 2 hours to cover this with a patient. When I see a new diabetic, I usually spend about 2 hours getting the information. But it could be broken up in different visits. It wouldn't have to all be done. I have found that if you pummel people with lots of surveys or questionnaires they fill out, they usually wear out before you do. So sending those ahead of time or using them or sending them at different times and gathering that information over a shorter period of time may be better. You'll just have to see for your clientele. Since I dealt with a fairly resource-poor, low health literacy group, I had to pair people with them. I had a community. You've met Fanny. So we would pair her with those patients to get that information filled out because they often had difficulty interpreting the instrument and answering in a way that would help us to get the best information. So anyway, some of you had asked me about type 2 diabetes, so I brought you, this is out of the Standards of Care. The American Diabetes Association developed this. They've had several instruments that have been developed and used in the past. I've used them quite a bit. I use them when I'm at large gatherings or health fairs, and showing people ways that they can assess for type 2 diabetes. So if you're in a practice and it's not exclusively diabetes, this is a good way to do a screen. This is a tool that has been shown to screen well for people at high risk for prediabetes or diabetes. So you might just take a look. I would guess that most of you will fall below the number for risk, but it shows you the things that are important, and it shows you the tool and how you can use it. The ADA, or American Diabetes Association, has their instrument online that you can download and use as well. So you might take just a minute or so to look that over, see what you score. Here, maybe you can have mine. So what do you notice those questions? Where have you seen those questions before? Talk about this. Risk factors. Okay, so they're picking out the risk factors that have the highest correlation with the development of prediabetes or type 2. So that's where they come from. And then they've assigned a numerical number to them, and then they've assigned a risk number to them that correlates well. So, questions or comments about those? Okay. Let's look at your handout then. So I started back with diabetes symptoms, just to kind of start with really what people might present with if they don't know they have diabetes, or they may come in complaining. How symptomatic people are going to depend on their age and what type of diabetes they have. For adults with type 2, we talked about this morning, it could be insidious. They may not have any awareness. They even may have symptoms, but they attribute it to something else. So they may come in without any awareness. You may find it on a random screen, and maybe you haven't seen them for a while, so you get a general screen and their high blood sugar shows up. Maybe they come in complaining, saying, I've been feeling this way. So on your differential diagnosis, you're like, I'm going to rule out diabetes. They also may come in and say, high family history, I've used my siblings' meter and I got a high reading. So it may come about from several different ways. With type 1, they're usually going to be more symptomatic. It will usually be more acute. Depending on the age of the child, they may have very different presentations. Sometimes young children actually present in coma because nobody's picked it up. It is a common cause of death in young children with coma that it's diabetes related. They may have a seizure first and then be diagnosed. So young children who can't communicate their symptoms as well may come in more severe circumstances. The onset of type 1 is usually fairly quick, but as you get older, those symptoms usually are less pronounced than acute. So they may have a more blatant onset of an autoimmune disease. So it will just differ in terms of age of patient, how long it's been going on, severity. Kayla, you want to tell them your story?
So I was diagnosed with type 1 diabetes when I was 18. I came in with, it was actually at a physical, which I should have came in way earlier, but I had every symptom, so my doctor was already like, oh my gosh. But I attribute it to lifeguarding and being in the sun. That's why I had increased thirst, I thought. I was peeing all the time. I probably lost 15 pounds, which I'm pretty short, so that was a lot.
In what length of time?
the weight loss was probably like 2 months, but they think I had it for maybe 4 months. The only symptom that isn't on here that I had, my vision actually got better, and then it worsened again when they corrected it. And then I had a lot of cramping in my arms and legs, and that was probably from dehydration. And then I would eat a ton and never be satisfied and still losing weight. So I probably should have went in earlier, but yeah, I didn't expect it because I was 18.
So you were diagnosed what month?
It was July.
Okay, so going back to March, anything you can attribute it to, onset?
Yeah, so it was actually the fall before I had strep throat, and my doctor thinks that may have triggered like a predisposition to it. It's not in my family at all, but they think that may have triggered it.
In your father's side, anybody with type 1?
Nope, on my mom's side, she has a cousin who has a son that has type 1,
Okay,
but that's the only thing we know.
okay. You have siblings?
Mm-hmm.
Have they been tested?
They haven't been tested, but they don't have any symptoms or anything.
So type 1, it is, what the history she gave is very, very common. Usually no one in the family's had it, but it does go a paternal route. So the father, if the father has it, more likely a child will have it. If your sibling has type 1, you are 3 times at higher risk of having type 1 than if you have no siblings with it. But the risk is still really low. So sometimes they will test the siblings of type 1s just to see, because they can measure antibodies already present and they can tell you your risk for it. There's lots of studies and registries that you can be in that will do that. So she gave a really good description. And the reason I asked her, was there something that marked that type 1 follows the spring and fall pattern. So usually where viral diseases are more prevalent, you will see the diabetes coming in after that. So we know that there are some viruses that will, in people who are predisposed, you have to have the genetic predisposition, and you come in contact with an environmental trigger that sets off the immune system, and they are, and then they attack their own pancreas and destroy it over time. Like type 2, it is a longer process. So the disease goes on. So if she says, well, inciting event may have been in September, she wasn't diagnosed until July. So that's about an 8 or 9 month time. So it is a quicker, it's not 10 to 12 years like, or 15 years with type 2 diabetes, but it can be months of that autoimmune or the immune ramp up and attack, and then you have to lose about 80% of your beta cells before you become symptomatic. So you can, once you get to about 10 to 20%, that's when the symptoms usually come up. So thank you, that was really a very good description. Okay, so let's look on page 3. We're going to look at diagnostic tests for diabetes and pre-diabetes. We do the same test, we just apply a different criteria for the diagnosis. So diabetes or prediabetes can be diagnosed based off of a plasma glucose criteria, or we can use an A1C. So plasma glucose criteria would be a fasting plasma glucose. This is commonly done. It has very good correlation with if you have your blood sugar in a certain range that you have diabetes. So again, a fasting, what did we say this morning? Fasting is done after how long? At least 8 hours. No caloric intake. So juice, those things that people may not think of as food. Man, I learned at the VA, what people define as food is not what you mean. So being very specific about caloric intake or something with a sugar in it is important. You can also do a 2-hour post or plasma glucose after a known load of a carbohydrate. So this is called an oral glucose tolerance test. So we give the person a solution of a sugar in a drink, and we have them drink it, and then we test them after 2 hours. Or this one, yeah, this one's a 2 hour. And then we have criteria at that point in time of where blood sugar should be. If it's above that, if it's, let's see, if you look at the next page, where do I put that? Oh, my little picture disappeared, shoot. Maybe not. Oh, on page 5. It shows you, now this is just the 2-hour mark, but it shows you what normal would be at 2 hours, what pre-diabetes would be at 2 hours, and what diabetes would be. So this is the most definitive test. It has the highest correlation with a positive result, but it's the least done because it takes time. So I use it mostly when I am unsure or I want to verify. So that's usually when other things are not telling us what the picture seems to be painting. The other is A1C criteria. So the A1C is a measurement of how much of hemoglobin A in the blood has a sugar attached to it. And it's actually the A1C the 1C is a part of that hemoglobin A. I'll talk more of it this afternoon when we talk about treatment. So this can be done in conjunction. I never use it. You can use it to screen for prediabetes or diabetes in an adult. They don't recommend doing it in children because there has not been good studies that have looked at using it in that manner, or enough studies. But I always use it in conjunction with a fasting plasma glucose. So let's see, so going back up, the fasting plasma glucose, you can do a finger stick, you can send them to the lab and get a venous draw, either one. The good thing about this is definitive, it is also cheap, so it's least expensive of the others. The A1C doesn't require a fast, so the other one requires a fast. This one doesn't require a fast, and it doesn't, it's not so influenced by day-to-day fluctuation. Whereas when you do a fasting plasma glucose, that is a point in time. But an A1C is giving you many, many points in time, average over about a 3-month period, because the life of the red blood cell is fairly long. It's less sensitive than a fasting plasma glucose. That's why they don't like to use it in children, is one of the reasons. You can do a finger stick. The machine down here is called a point of care testing machine. You can have it in your office and you can run a test and have it available in 6 minutes. The little next to it are the cartridges. So you can purchase these. You have to have a special license called the CLIA license to be able to do that. In our diabetes clinic, that's what we did because we could get fast results. Or you can send them to the lab. You can do a venous draw and get an A1C probably by the next day. It's more expensive than fasting blood sugar, but I like it because it gives you more information and it's more sensitive to all the variations that have gone on in the last 3 months. So I like to see it. You can have a normal fasting blood sugar and have a higher A1C. So remember when we talked about those, that usually the initial problem in diabetes is resistance, and that the blood sugar after a meal goes up higher first than the fasting. This will pick it up. A1Cs are much more sensitive to the variations in glucose excursions that happen after you eat. That's why I like to use both of them. But there are drawbacks. So if there's anything wrong with the hemoglobin, then it won't be a valid test. So people have hemoglobinopathies. Thalassemia would be one. If your predominant hemoglobin is not hemoglobin A, then this one won't pick up any other hemoglobin. If you have an abnormal turnover of hemoglobin, like sickle cell anemia or a hemolytic anemia, you're turning it over too fast for there be enough glycation to represent blood sugar and to get a valid test. If you have a lot of blood loss and replacement, so somebody who's had a major bleed or has had transfusions, we don't use it because it takes a while for that blood then to be exposed to the sugar enough to adequately reflect what A1C is. And also if they're on erythropoietin therapy. So who would that be? Who's on erythropoietin?
Kidney patients.
Kidney patients. Okay. So let me give you just a snapshot of hemoglobin A1C. I forgot I went ahead and put this in. So the predominant hemoglobin in adults is hemoglobin A. It makes up about 90% of your hemoglobin. When you're born predominantly hemoglobin F. So your hemoglobin species changes until you get to be an adult. So hemoglobin A, and the subfraction that's most common is the 1C. That's about 80% of your hemoglobin A. That's what we're measuring because it's the predominant hemoglobin. So hemoglobin A, it's a protein. When proteins come in contact with sugar, the sugar will glycate the protein, forms an irreversible bond for the life of that protein. So red blood cells, we like to use them because they are around for about 120 days. So when the hemoglobin becomes glycated, it stays that way for the life of the cell, and we can test it, and it will tell us and we can convert the percent into an average blood sugar. And so we can look back about 3 months and see what the average blood sugar of someone has been during that time. Now, if the person's unstable, it's not as reliable, but it's really a helpful piece to look at when you are trying to figure out the glycemic state of someone. So this picture shows you the difference between a hemoglobin that's got lots of glucose attached to it versus one that doesn't have as much. This little thermometer, you have to look hard, but normally, if you don't have diabetes, if your blood sugars are normal, then you are going to have about 4 to 5.5% of your hemoglobin A1C with a sugar attached. So everybody has a positive hemoglobin A1C, everybody. But the more sugars around, then the higher that glycation percent goes up. So what we can do, now your lab will do it for you. Your lab is going to give you a conversion. So if we say that 100 milligrams per deciliter is a good average blood sugar, that person would have a A1C of about 5%. Okay? For every 1% change in hemoglobin A1C is equal to about 25 to 35 milligrams per deciliter. Okay. So somebody with an average or an A1C of 6% has an average blood sugar of about 125 to 135. That means about half the time they're above that and half the time they're below that. Okay. So if let's say we went up to 10%, you get back a hemoglobin A1C of 10%. Or we know that 100 is 5%, so we're 5 units or percentage points above that baseline. So if we take 5 times 25, what do we get? 125. And 5 times 35 would be 70, 140, 175. We would add that to 100, because that was what we called our base. And so that gives us our average. So 225 to 275. That's their average blood sugar. Your labs will give you back. I like to be able to eyeball it and tell them while I'm sitting there, especially if I'm doing a finger stick. Okay, just follow how I did that. Okay. What should their average be? Should be closer to this. Okay. Okay, just returning to the 2-hour plasma oral glucose tolerance test. This one is the most sensitive. It will diagnose the most people with diabetes. But again, we don't use it very often. Here would be an example of when I would use it. Had a lady who was referred to me, she had neuropathy already, and actually, backing up on this woman presented with neuropathy, was sent to a neurologist, and his first thought is, you've got diabetes. Her blood sugars came back normal when they tested them, so he did an OGTT, and that's where it showed up. Her A1C was about 6%, but she had really high excursions, but she could come back down to normal. But she had had it long enough that she presented with the neuropathy. I saw several patients in the VA that was the first time they knew they had diabetes, was when the neuropathy was diagnosed. Okay, so questions about those. So those are the 3 tests you can use. Fasting plasma glucose you're going to use the most. And if it comes back positive, you should, if you didn't get an A1C the first time, you should just go ahead and get that, because it'll start to tell you how long has this been going on, what's the severity of it, and can help direct therapy somewhat. So pre-diabetes, how do we diagnose that? There's 2 types of ways to look at a pre-diabetic state. One is an impaired fasting glucose, so their baseline blood sugar, their fasting blood sugar is in that 100 to 125 milligram per deciliter range. Or they can have impaired glucose tolerance. So on an oral glucose tolerance test, their blood sugar came back between normal and diabetic range. Okay. Either one of those can be called prediabetes. People at the highest risk for progression to diabetes have both. They have an impaired glucose tolerance that shows up postprandially after they eat, and their fasting blood sugar is already elevated. So the reason to diagnose people with prediabetes is 20% of that population will move on to have type 2 diabetes within the year. That's a high percent. So all of those people within 5 years would expect it to be moved into the criteria to fit diagnosis of diabetes. So pre-syndromes, pre-conditions are really important when you know that they progress on to a chronic disease. So identifying those people, screening those folks, important. The same risk factors for diabetes exist for pre-diabetes. Okay? So that when they walk through your door, even if they don't ask for it, you need to screen them. You will be doing them a favor, I'm telling you. Even if their stuff comes back normal, their lab values come back normal, they can still have risk high enough that if they proceed down that path, they may eventually develop that prediabetes state. A1C, I like to use it because they can vary. So people don't just stay the same number all the time, they vary. So I like to use A1Cs in that case to help solidify the diagnosis. So an A1C of 5.7 to 6.4% is for prediabetes. So for the diagnosis of, do you need to say something? Nope, you just want to.
I'm gonna rant again.
Okay. So diagnostic criteria diabetes, you must know these. Okay? So an A1C of 6.5% or greater, a fasting plasma glucose of 126, it should be equal to or greater. I left off the underscore there. The fourth one is an OGTT where the 2 hour is 200 or greater. Those usually help to diagnose type 2s. For type 1s, usually what will happen is that they will come in with classic symptoms, just like Michaela did. You draw a blood sugar and it's greater than 200. So a random, which means without regard to a meal, so fasting is always in regard to time without a meal. Random means the meal could have taken place any of that time, shorter than an 8-hour, because then it would become a fasting. So a random blood sugar, greater than 200, and classic symptoms of hyperglycemia, you can call it then. In any other circumstance, you would confirm the diagnosis. You never want to give people a diagnosis of diabetes unless you are absolutely sure, because it affects their life. It can affect employment, can affect their license, can affect other aspects. So be very careful once you do that. Okay, so the classic symptoms, the 3 Ps, polyuria. Why do they get polyuria? Okay, so it's the sugar, it's the high sugars overwhelming the kidney threshold for reabsorption. It's spilling that sugar into the urine, water follows it, so they get polyuria. Where's the polydipsia come from? Osmolality goes up, and so the osmoreceptors in the hypothalamus make you drink, make you thirsty. Where's the fatigue come from? Can't access or utilize all the energy that you're taking in through your diet. Where's the weight loss come from? Okay, breaking down of energy stores, lipolysis, protein. You can't hang on to all the energy that you take in. Okay. Blurred vision, where's that come from?
Sugar in the lens.
Glucose enters the lens, water follows, it swells. Your ability, so your accommodation, so it's your short-term vision. Sometimes I pick it up with people that I can't read the paper anymore, or I went to get my eyes checked. Sometimes people even get prescription changes. They go to an ophthalmologist, they're usually good enough to check a blood sugar, and they won't do that. They won't change the lens for them until their sugars get under control. Okay, so those are classic symptoms. Here are some patients' stories that they've told me when they knew something was wrong. So I saw probably a little girl, she's probably 8 or 9, 7 or 8, somewhere in that range. And her grandmother told me, she lived with her grandmother, and she said, I knew something was wrong when she would turn on the bathroom faucet as high as it could and stick her head under there to get enough water. That was impressive to me. Had another guy, he was probably late 40s, early 50s. He was a parole officer for the, not a parole, he worked with kids that were in trouble, and he did it all over the state. And so he traveled a lot in the rural areas of Oklahoma, and he said, I knew that when I got a 5-gallon tank in the back of my truck, and I drank that every day, I knew something was wrong. So see, it's over and beyond. Sometimes it'll be, I'm getting up and peeing every hour at night. I can't sleep anymore. Similar things. So they're dramatic. So if y'all are sitting there going, man, I'm thirsty all the time. Well, keep it in perspective. Keep it in perspective. Okay, questions about those? Okay, so diagnosing a type 1. With type 1s, blood testing is preferred. With kids, blood testing is preferred instead of an A1C as the sole diagnostic test. The other thing we can do with type 1, because it's an autoimmune disease, is we can test antibodies, the presence of antibodies. So we almost always do that, confirmatory. Those antibodies live or stay in the blood for quite a length of time. So the ones I've listed once for you there that are more common, usually you get 2 because sometimes one will not show up. So GAD65 is probably one of the more common ones that people get, but it is not specific for type 1. Thyroid disease, autoimmune thyroid disease will do that. So you usually have to get another one. But it's very common and it stays around a long time. That's why we will usually get it. Islet cell autoantibodies, we usually will get one of those. So like the IA2 down there is a very common one. It's specific for type 1. So I usually pull it and a GAD65 and get those. Now I dealt mostly with adults, but even in kids, that's usually what the peds endo folks would do, is they would always do antibiotics. They take a while to get back. They can take, depends on the lab and what access you had, but usually I would find it would take 6 to 8 weeks to get the results back. But I would use them in adults when I could not determine if I was dealing with a type 1 or a type 2. So one of the things, if I was dealing with a patient who I suspected had type 1, but they were resistant to insulin, the next thing I would get would be a C-peptide. I didn't put this one in. I'll make sure I include it in the handout tomorrow. We'll have more information on it. So what do you remember about C-peptide? It's a byproduct of what? Okay, insulin transformation from pro-insulin to insulin. So proinsulin is the storage form. Remember, it has that structure, 2 chains with disulfide bridges between. Before it is released, the little enzymes in the lysosomes cut that out, and you end up with insulin and a non-pharmacologically active C-peptide. Molar for molar, equal molar. So if you measure the C-peptide, you know how much insulin they're producing. Okay. So if this is low, let's say it's still there, but it's awfully low compared to the amount of sugar they have in their blood, and I've got high sugars, and I've got a history that I think is consistent with type 1, patient is still resistant to that diagnosis, then I'll also draw antibodies. That's what I do in adults. Did they draw antibodies in you?
I don't recall that, but I'm sure they did. I had to do a urine test. Yeah, they drew my blood, but I didn't know what it was.
They may have, and it just confirmed, and so they
Yeah.
already were down the road perhaps. I had a lady one time who was sent to me by one of the doctors in family medicine, and he said, I want you to teach her how to do insulin because she's lost a lot of weight, and whatever she's got, I think she needs insulin. So she came over to the clinic, and I started talking about insulin. She goes, I am not doing insulin. And I said, well, went through all the reasons, tried to tell her why, explain. And she said, look, I'm Native American. She said, there is no way I have type 1. She said, I think I have type 2, and so if I have type 2, I'm not taking insulin. She was very smart, very well educated. Well, her back history is that she had weighed 200 pounds several months before that. She was down at 140 when I saw her. And she said, I'm not going on insulin because I know I'll gain that weight back and I won't do it. And she said, and I'm not going on insulin, nor will I consider it until I'm below 120. So she was using it for weight control, which young girls will use that. They'll let themselves get really hyperglycemic because they can lose weight rapidly. So in her, I eventually got her to agree to all these tests, and it confirmed she had a type 1. So in adults, they have a type of diabetes that is, it's type 1. Type 1 can appear at any time. I've seen it in 90-year-olds. But it's less likely as you get older. But there is a type 1 in adults that's called LADA. Latent autoimmune diabetes of adults. So what happens in adults is that in kids, the immune response is really fast and powerful, and they get symptoms quickly, and they appear sick, and they're diagnosed fairly rapidly. In adults, the immune response is usually much, much slower. And so that's why the term latent gets put in there. So what usually these people will present, they'll have really high blood sugar, somebody will put them on oral agents, and within a year or two, they need insulin. And I usually find that about 5 to 8 years, they need fully insulin. But that is what's happening with them, is that they're just killing off their beta cells at a much, much slower rate. Ron, put you in charge of remembering where I put down.
Dr. Lassie, is
Yes.
this, I'm sorry if you already said this, but is it common to do those autoimmune markers in primary care?
Yes, well,
Because I would assume that would be like with an endocrinologist or at a diabetes clinic, but I saw tons of diabetic patients and I had never even heard of these, so that's why, when I read the textbook on this chapter, it was saying that the GAD65 and the tyrosine phosphatases were uncommon, so that's why I was, which I didn't
uncommon,
believe
what do you mean, are uncommon from
It just said that they weren't commonly done.
common tests done?
Yeah.
Well,
I'm sure in relation to the fasting glucose and A1C, but I was just curious if this is like something we should do with all of our diabetic patients, or?
here's what I would say, unless you're working in a type 1 facility that primarily sees type 1. In this area, we are blessed because we have a fantastic pediatric endocrinology group. We have 2 of them in the city, and one of them being at OU. They are excellent the way they do. So what I would do is if I would see, and I would find kids occasionally that were sent to me that were thought to have type 2 and had type 1. So what I would recommend that you know where your pediatric endocrinologists are and you get them in as quickly as you can. Now, they may say, while you got the kid there, go ahead and draw these. The problem is that because we have become a heavier society, we have drugs now that can cause a DKA. When somebody presents in DKA, we don't always know if they're type 1 or type 2. 30 years ago when I started training, came in at DKA, we knew they were type 1. The pictures are blurred now. So that's why sometimes people can present and look like a type 1, but they're actually a type 2. So that's where it gets hard. And so that's where those autoantibodies really become important. Here's the reason why. Kids can die from type 1. So if you miss the diagnosis and you start them on and don't get them on insulin quickly, they can really crump fast. So that's the reason to do it.
I think I also misread it, and as I'm looking at it again, it says the ADA doesn't advocate screening for diabetes with them. But I guess
Yes,
I can
that's
see-
true. That's very true. So what I said to Michaela with her siblings,
Sorry.
they don't recommend just like primary care screening her siblings. They really recommend you get them enrolled in a study or a registry that's following. Because then what they can do, depending on what the results come back, they can advise you more. Here's what you do, watchful waiting. The picture that we see is more serious, or you need to be more aggressive. Or they can tell you of the studies that are looking at prevention. And a lot of prevention studies for type 1 deal with siblings or first-degree relatives of people who have type 1. So I'm glad you brought that up because it probably isn't used very much. I think that if we had not had our clinic in family medicine, it probably wouldn't ever be done. But the biggest thing is to know where your resources are. Your peds endos are usually so good and they're geared to deal with kids. Because with kids, you've also got the parents. And the parents need lots of education. There needs to be assessment of the household and the support. And there needs to be ongoing communication. So they really need that. Type 2 is very different. Anybody else? Okay, diagnosing type 2. To diagnose a type 2, you can use any of those approaches. You can use a fasting, you can use a A1C, you can use a OGTT. Whichever one you do, it's recommended, except for the OGTT. You don't have to do those. But if you're going to use a fasting plasma glucose, confirm it. Use the same test to confirm. So if you look at the guidelines, it will say 2 or at least 2 readings of fasting blood sugar that are greater than or equal to 126. People can vary. So I don't do it when people are sick. I don't do it when they're stressed. I don't do it when something unusual has happened in their life. Wait till they're stable, then test them to get the cleanest. Okay. For gestational. So for gestational, the recommendation is that you test at 24 to 28 weeks gestation. Pretty much all women will fit this. If you remember when we talked, I guess the last module, there are women who have no family history. They're less than 25 years old. They're at their ideal body weight. They're not in a high-risk ethnic group. Okay, most people don't fit that. They'll have one criteria that will put them at a higher risk. So it's really recommended that everyone be screened in that 24 to 28 week time. There is a one-step approach and there's a two-step. In my experience, most people use a two-step approach. So the two-step is you just screen everybody with a non-fasting 50-gram load of glucose. Okay? It's just a real syrupy, sweet, they carbonate it, they get it cold, you drink it down, and then in an hour, I think it's an hour, they check your blood sugar. If it's greater than 140, then they will do a full test. Full test is 100-gram glucose load, and then they check your blood sugar fasting, 1 hour, 2 hour, 3 hour. So you can see why people don't want to do that, because you have to hang around a long time, or you hang around until you meet the criteria and then they call it.
Okay, so maybe I was the only one, but on the test, we had a question in regards to glucosuria.
Yes.
At 20 weeks, what does that indicate? What does that warrant? Like, should we go ahead to the oral glucose? Or should we just suggest lifestyle changes? I mean, I would want to know more information, but I was kind of confused on that. I don't
You
feel
should
like I got it
confirm that.
clear.
If they have sugar in their urine at any point up until that time, you should do further
Oral
testing.
glucose, most likely.
Yeah, you could go ahead and do that. You could do a blood sugar. And the blood sugar goals for pregnancy are different than for people with diabetes. But yes, anytime you can identify it early, it's better. Some people have pre-existing diabetes, don't know it's low grade enough, they don't pick it up. And urine doesn't correlate well with the blood sugar. So that's why you never go off of just a urine. Yeah, good point. Okay, you don't have to know those numbers. There are 2 different criteria for this, I just gave you one of them. All right, any questions on the testing to this point? Okay, all right, since we're gonna start screening, let's go ahead and take a break and come back a few minutes before 2 and we'll pick up on page 6.